Okay, good afternoon, everyone. I will be talking about the pharmacological aspect of the pupillary expansion. So, first coming to how does the pupillary dilatation take place? The constriction of the pupil occurs via iris sphincter muscles, which is controlled by the parasympathetic pathway. And similarly, the pupil dilatation occurs via iris dilator muscle, which is controlled through the sympathetic pathway. It's an autonomic nervous system pathway which begins in the hypothalamus locus areolus, and via the superior cervical ganglion, it innervates the iris dilator muscle. The iris dilator muscle, these are the radial muscles which have got sympathetic innervation, and when stimulated, they release the noradrenaline, which then act on the alpha-1 receptors. That's why during the state of fear, excitement, or arousal, the pupillary dilatation takes place. So why do we need to dilate the pupil? We need to dilate it for various diagnostic procedures like refraction, to have any nuclear this grading of the cataract, and for fundus evaluation. Surgically, we use it for every intraocular procedure. And with cataract surgery, it has become paramount importance because with the recent advances in the phaco techniques, the ease of this pupillary dilatation, it has improved the post-operative outcome and there are less complication rates. It has become one of the prerequisites for safe cataract surgery. Appropriate mydriasis and inflammatory control, they are key to a surgical outcome. So, as you already know that the pupillary size of 5 to 5.5 is the acceptable size to make a good capsulorhexis of about 5 mm. But poorly dilated pupil, it is one of the most common difficulties that is faced by the surgeon. You can see here's a poorly dilating pupil, and with the installation of the mydriatic, the pupil dilates. It is not just a geometrical issue which limits the access to the surgical field, but is also there are several factors that affect the pupillary dilatation, which cause an increase in the blood aqueous barrier. And we did know that after a poorly dilated pupil is present, there will be increased risk of post-operative inflammation. Some of the common causes are prior ocular surgery or trauma, chronic uveitis. In chronic angle closure glaucoma, where the patient is on chronic meiotic therapy, we have to start at 3 weeks prior to the surgery, in pseudoexfoliation syndrome, and in senile sphincter sclerosis. In the systemic causes, diabetes mellitus is one of the most common cause, where there is glycogen deposition, neurosyphilis, and substance abuse. In the drugs, we have tamsulosin, which is commonly used for the treatment of BPH. We have substance abuse like phenytoin, morphine, heroin. IFS, when there is systemic administration of alpha-1 receptor antagonist tamsulosin, there occurs billowing of the flaccid iris stroma to normal intraocular currents, propensity for the iris prolapse to main incision and side port, and there is progressive pupil constriction. So in case what are the challenges which are faced by a surgeon during the surgical procedure? The small pupil gives less surgical space, which leads to lesser capsulorhexis. Then there are higher chance of anterior capsular tear, posterior capsular rupture, increase in the vitreous by a factor of 2, and increase in the post-operative inflammation. So whenever we know that there is a small non-dilating pupil, we have to take the steps to prevent it. Careful preoperative evaluation, we have always to know what is the cause of small pupil, and then we have to take a careful medical and ocular history. Following an algorithm can be helpful. Then the pharmacological dilatation, this is the standard practice. We have to achieve maximum pharmacological dilatation. We got topical mydriatics, topical cycloplegics, and topical NSAIDs, then intracameral mydriatics and viscomydriasis. The preoperative mydriatic regimen that is followed is phenylephrine, tropicamide, cyclopentolate. Atropine is not commonly used because it has got a long duration of action. The standard protocol is sympathomimetic mydriatic like phenylephrine in a concentration of 2.5% and parasympathetolytic cycloplegics, either tropicamide or cyclopentolate. And studies have shown that NSAIDs, especially ketorolac in concentration of 0.5%, help us to prevent the intrameiosis. There are certain intraoperative measures which we can follow after the topical administration. Midriacert is a new drug that has come in the market. It's an FDA approved. It consists of an oblong shaped semi-permeable capsule which has 0.28 milligram of tropicamide and 5.4 milligram of phenylephrine. It is placed in the inferior fornix 60 minutes prior to surgery. We have to take care that make sure to remove it before the surgery. So phenocaine. Phenocaine is the drug that has come in the market. It consists of tropicamide, phenylephrine, and lignocaine. It can be used intraoperatively. This is a small non-dilating pupil. We can see the pupil dilates beautifully intraoperatively. The placement. Episugarcane, that was launched by Joel K. Sugar in 2006. It is especially helpful in patients with IFIS. It overcomes the action of alpha-1 blockers such as tamsulosin. It consists of 4% lignocaine, which is then diluted with 1:3 BSS. But what is the disadvantage of any homemade cocktails? There can be dilution errors, accidental use of medications which are containing preservatives, which can lead us to toxic anterior segment syndrome. So there are certain FDA approved drugs like migraine, which has tropicamide, phenylephrine, and lignocaine available. Non-preservative epinephrine, it can be used. What is the problem with this intracameral? That there is constant washout with the irrigating solution. So another thing is we can mix it in the irrigation solutions. They have been proven to be non-toxic to the corneal endothelium. A combination of phenylephrine 1% and ketorolac 0.3%, which has been launched by the name of Omidria. It has been recently approved by FDA. It prevents intraoperative miosis and postoperative ocular pain. It is also mixed with the irrigating solution, and constant irrigation can be done. After we use the maximum topical medication and then the intracameral midriatic, still the pupil is not dilating, the next step is to go for viscomydriasis. We use OVDs, the sodium hyaluronate 2.3%. The advantage is it causes intraoperative pupillary dilatation and the physical barrier to decrease the iris billowing and prolapse, especially in IFIS. But viscomydriasis is more successful in low phaco settings. In case we have to do high vacuum settings, there was a technique which was formed by Steve Arshinoff known as soft shell technique. In this, we put a dispersive viscoelastic which coats and prevents the cornea, and then a cohesive viscoelastic to flatten the capsule. So to conclude, topical medications and intracameral medications, they help us to achieve dilatation in 90% of the cases. We have to know everything best that is in pharmacologically. The first thing is to ensure maximum dilatation before starting the surgery. Topical midriatic drops, topical NSAID drops. Next is we have to have an optimal dilatation. Surgical spawn soaked in 10% phenylephrine in the inferior fornix 30 minutes prior to surgery, but always make sure to remove it. And then we have to maintain the dilatation during the process of surgery. We can do it with episugarcane, midraine, midriatic with or without NSAID in the irrigating fluid. After that, intracameral preservative-free phenylephrine, OVDs with low flow and vacuum setting, bimanual sphincterotomies and bimanual stretching and sphincterotomies after we're done with the pharmacological part, and then the pupillary expansion devices. So we always need to have a small pupil management algorithm. It will help us to achieve adequate pupil size with minimal risks. So know your pharmacological agents, then mechanical expansion devices, and we can get optimal surgical visualization while following this algorithm. Thank you for your patient hearing.